Onc Live Insights is a video editorial program produced by Onc Live.
Most of the follicular lymphoma patients after first-line treatment can achieve a good remission, and those patients can be, again, going through the watch and wait stage. Upon detection of early progression, the treatment indication is pretty similar to the first-line treatment, meaning that you can still watch and wait for patients who are having asymptomatic disease and only considering treatment if patients are developing symptomatic or bulky disease that's causing impending organ compromise. However, the one exception is that if you're noticing a patient who are having rapid progression of disease, so even if they have not developed bulky disease, you may want to consider early treatment. So that's the timing of the treatment. In terms of considering the options of treatment, I think besides thinking about what are the available agents, the other important thing to consider is how well did the patient respond to their first-line treatment, what kind of qualitative response did they achieve, and how long the treatment response lasted. So if someone had a very good response, like a complete response, which lasted for 4 or 5 years, it's a very good consideration to consider repeating the same our chemotherapy as the first-line therapy. So that's one option. But there are also a lot of emerging options, novel treatment options for relapsed follicular lymphoma.
The treatment of patients with relapsed or refractory follicular lymphoma depends on a number of factors. Number one, what was their initial treatment? If they had R-bendamustine up front, I'm unlikely to use it again. If they had R-CHOP up front, you can't give it again, but you might consider R-bendamustine. There are a number of factors I take into consideration in the decision as to what to offer patients with relapsed or refractory follicular lymphoma. The first of these is, what did they receive as their initial treatment, and what was the quality of the response to that therapy? There is a distinction between relapsed and refractory disease. Refractory disease suggests the patient got less than a partial response or got a response, but it lasted less than 6 months. That's the operative definition that we currently use. If a patient had, for example, bendamustine rituximab and relapsed 3-4 years later, you could theoretically use it again. You can't use R-CHOP again. If a patient had R-CHOP, you could salvage them with R-bendamustine. If they started with R-bendamustine, there are no data on the efficacy of R-CHOP in that context. But things are changing. Things are completely changing. Now with the availability of some of these novel drugs, the best choice for relapsed refractory patients is unequivocally a clinical trial that will get these new drugs to market, that will test combinations of these new drugs. In the absence of an available clinical trial, then idelalisib has become a very common drug that I prescribe for patients with relapsed or refractory follicular lymphoma.
So often our patients will have very good responses to one therapy, and a very important question that arises is whether or not we can use that therapy again. The most important factor in deciding whether or not a therapy is worth being used again is really going to be the response duration. And if a patient has sufficient duration of a response, then it certainly is a viable option to use that therapy again. It's also important to add to that consideration the toxicities associated with these agents, because of course using the same agent a second time does allow for basically the patient to be exposed to overlapping toxicities a second time.